questions you guys have also, because I know as a BDS student you will have a lot of doubts about how resective osseous surgery it works and what is it, and is it a big treatment or a small treatment or whatever, everything. Okay, so let's just quickly I'll share the thing. You can't do a proper flap closure. That is point number one. Point number two is cases, what happens sometimes when you do like different kinds of treatments, you have corticotomy cuts which you need to give. Like example, in this orthodontics they have given corticotomy cuts between the teeth. Okay, um, pocket reduction, osteectomy, osteoplasty, again for a smoother flap closure, altering any bony exostosis. We have bony protuberance which we saw. If we want to flatten that, is to make the patient maintain the oral health very easily. So anything which is hampering that needs to be removed. Mainly these two are divided at the base of, are you causing any harm to the surrounding structures of the tooth?
Do you enjoy learning without distractions? Download our app now.
Okay, perfect. Before I actually get into resective osseous surgery, let me just get show you one case scenario which I had. Okay, so this was one of the patient who came to me, a 35-year-old. She had a complaint of food lodgement. What would you guys see? Like, you guys tell me what is the problems in this? Like, what do you see? Okay, bone growth is increased. Anything else? Black triangle. Okay, very good. Excellent observation. Okay, let's just come back to the patient. Her main problem was food lodgement. Food lodgement in 1/6 was her main issue. Okay. So what we had to do was we checked the probing depth. It was 7 mm over here. So 7 mm deep periodontal pocket was there. So we took an IOPM and we found a vertical defect. Can you see a vertical defect over here? So now we know that there is a problem. There is a bone defect over here, because of which there is food lodgement. So we need to correct the defect over here. Okay. So then what we did is we did a surgical procedure. Now, coming to surgical procedure, for most of the vertical defects, bone graft is the option. Now, we didn't want to use any allograft or available chemically made bone graft. So, you know what we did? We know that in the first picture when we saw, you can see the bony exostosis over here. This any protuberance of the bony, like this projections are called as bony exostosis. Okay. Now, when so what we did is we did a small incision over here, open the flap. We could see this bony ledge over here. So we took some bone from there. That's an extra bone which is available over there. Okay. So we took little portion of that bone with the help of bone ronger. So this is the bone which we got, that is called as autograft, because we are taking from the same person. Okay. Then we place that bone graft in this vertical defect over here. In 1/6 mesial aspect, there was a vertical defect. So we placed the bone graft over here. We placed a collagen membrane on top of that. We placed a collagen membrane that. Then this bony protuberance which we had, we just flattened it over there. We sutured it back. And yeah, so this is the result of post 1 week. Post 1 week, when we took the picture, we found. Can you see the bony protuberance over here? Can you see it's become flat? So what I would like to say is resective osseous surgery, if you ask me what it is basically resection of the bone. Resective means resection. Any part of the bone removal is called as resection. Recently somebody asked me what is the difference between dissection and resection. So dissection is you're dissecting the human being, or you're dissecting and you're looking into the parts inside the human body. But whereas resection is the removal of that part of the body. It can be any part of the body which is called as resection, but here we're talking about resective osseous surgery. So let's go back to our main topic, which is resective osseous surgery. Okay, so anything which we are doing to the alveolar bone, be it reshaping of the alveolar bone or recontouring of the bone, or you're doing any removal of the bone for any purpose, or you're regenerating the lost bone. All of this comes under resective osseous surgery. Resective osseous surgery itself is not another treatment. It can be part of any other treatment. Like you have you're removing a part of bone for a particular reason. That is resective osseous surgery. But when you're doing an open flap debridement, you remove the debris, but you can see that there is a small bony ledge over there. So you smoothen. That itself is called as resective osseous surgery. That was not the intended treatment for that. But when you opened the flap, you saw that there was bony irregularities, so you smoothen. That also becomes a resective osseous surgery. So this itself is not an entire treatment. It can be part of any other treatment as well. Okay. So to understand resective osseous surgery, you need to know the normal bone physiology actually. So if you see the normal bone physiology, it is exactly nicely scallop formatus over here. Okay. So if anybody asks you, this is called as the positive architecture of the bone. Okay. Where you have the interdental bone, which is coronal to the buccal or the palatal bone. Always the interdental or the proximal bone should be at a higher level than the buccal bone or the palatal bone. So this is a major part where we call it as a positive architecture of the bone. Anything. Now, if there is a bone loss which happened over here, it becomes a flat architecture. Like it becomes completely flat all around the place. Or sometimes further defect happens where the interdental bone is over here at this position. So your buccal plate is at a higher level and the interdental bone is over here. We'll see the osseous defects later. So probably you'll understand better. So that becomes a negative architecture. Okay, so this was just a general idea of the how a bone actually looks, normal morphology. Let's talk about now the definition of resective osseous surgery. Okay, now coming to resective osseous surgery, you can see all the different types of osseous defects which is seen on the bone. Okay, you can have a small bone kind of defect over here. You can see there are so many irregularities in this marginal bone. You can see there is a depth of a bone over here. There is some bone loss happening over here. From the occlusal point of view, because of periodontal disease, there is bone loss over here. In between furcations, there is bone loss over here. So all this comes under osseous defects. So if you ask me what is resective osseous surgery, any changes to the bone, like reshaping of the bone or recontouring of the bone or regeneration of the bone, you're doing to the bone, that is called as resective osseous surgery. Okay. So let me repeat. Procedure by which deformities in the bone are eliminated by surgical reshaping or recontouring of the bone is called as alveolar bone. Okay. Now, what are these caused by? Like, what are these osseous defects caused by? Okay. Now, the deformities are caused by mainly one reason, that is periodontal disease. Okay. Can you see over here? So, periodontal pathogenesis, how it happens, everything I'm not going to explain here, but general idea, there's accumulation of bacteria, calculus, everything happens here. Then there is a breach in the junctional epithelium, it goes inside. Then there is bony defects happening. So this is a vertical defect, can you see over here? So this is one of the osseous defect. So one of the major causes of these deformities is periodontal disease. What are the other related factors? Now, if you talk about other related factors, you have one of exostosis. Coming back to the case which we saw, the bony protuberance outside, exactly that over here. Okay, so it can be happening in the mandible as well as maxilla. So this is a maxillary picture. So this is called as maxillary exostosis, but it can happen in the mandible as well. The other is because of tooth supraeruption. Now, when you see this is tooth supraerupting, because the lower teeth is missing, the upper teeth is trying to come down. So when that happens, can you see the bone level over here? There are changes happening in the bone level. So those are the osseous defects happening because of supraeruption. Even if you see here, mesial inclination is happening. So when mesially inclined, you can see there's a lot of osseous defects happening over here. So that is again another cause for osseous defects. Overall, mainly caused by periodontal disease, and other related factors may be exostosis or tooth supraeruption. Okay. Now let's go to indication. Now, where and all will you use this, uh, you know, this kind of resective osseous surgery? One is, as I told you previously, this is the positive architecture which we have. Now, can you see the negative architecture over here? The interdental bone is below the buccal bone. So that becomes a negative architecture. Or you can see a flat architecture as well, when it is completely flat over here. Okay. So, so the one of the major indication for this is flat or reverse bony architecture. Okay. Then comes, as we saw in the case again, exostosis or ledges. Ledges are also nothing but any like small kind of bony protuberance in when you open the flap, you can see. So those are called as ledges. You need to smoothen that, because when you have this, no, you can't do a proper flap closure. That is point number one. Point number two is there are more chances of bacteria, retaining over here. So it's very difficult for maintaining the oral health. So that is another reason why these ledges are, more prone to bacterial accumulation. Again, third is small shallow defects. I was talking about the ledge, right? So in this picture you can see a ledge very clearly. Can you see a ledge over here? So this thin marginal bone, which is very dangerous actually, because it harbors the bacteria over here. So we need to smoothen it out, so for easy maintenance for the patient. So one of the reason indication for resective osseous surgery is ledges and shallow bony defects, like very small bone defects, less than 3 mm we have. That is one of the indication. Next indication is furcation. So what happens is, when you see over here in this portion sometimes has bacterial accumulation. So then there is bone defect over there, that is called as furcation defect, furcation involvement. So sometimes what you can do is, you will have to remove a bone over here, make a through and through hole for easy cleaning. So we give a small interdental brush kind of thing, which can go through the furcation. So patient can maintain there as well. So through and through this itself, we give a small brush for them to maintain. So at that time, we reduce a small portion of a bone over here. So that is one of the indication for grade 1 or shallow grade 2 furcation areas. Then we have bony contouring. So can you see the bulky bone which is seen over here? This is like overall, this is not called as exostosis. This is the contour of the bone itself is very bulky. So at this position also, to maintain the aesthetics, or sometimes we have to do the root resection procedure. Then while we do the open flap debridement, after debridement, can you see a small portion of a bone over here? So this again harbors bacteria, all that. So what we do is, when we open the flap, we do the debridement and everything. Again, if we close back, there are more chances of bacteria staying here again. So what we do is, we rounded this edge over here, and then we close it for a better adaptation. So regenerative procedures to achieve primary flap closure. Okay. Now these were the indications, like where it is being used. Now let's talk about contraindications, where it cannot be used. So this is one of the case where aesthetic concerned areas, when we have to be very careful, because sometimes when you do excessive bone removal over here, it can lead to recession. Okay, so that's why we need to be very careful in these kind of areas. Then we have extensive bone loss is seen, severe bone loss. Like already the tooth is compromised, there is overall bone loss. Over that, if you do all this resective procedures and all, that tooth is not going to stay there. It's just going to come off within very few months. So when you have severe bone loss like these, we contraindicate that case for root resection. Then root hypersensitivity. So already there is a root recession over here. Already the root is very sensitive. So in this case, if you do any bone resection procedures around this, there are more chances of hypersensitivity happening over here. So that's why we avoid such cases as well. Then coming to close proximity with the sinus. in the maxillary sinus area, we have to be very careful because then perforation happens, then the pain is unbearable for the patient. So always when the bone is related and if it is in the close proximity to maxillary sinus, just stay away from that case kind of thing. Okay. And then all um, this, so this is another mandibular ramus near the ascending mandibular ramus or the external oblique ridge. So here it's risky to do because it is very close proximity to the nerve over there, mandibular nerve. So we avoid that area as well. Okay. So these were the contraindications. Coming to the different types, let's talk about the different types. So we have two types of osteosurgery, broadly classified. We have additive osteosurgery. Additive osteosurgery is adding the bone graft. Can you see the bone grafts being added over here? So as you can see the name itself, it's regeneration of the bone which is happening. So that becomes additive osteosurgery. Okay. Then this is subtractive osteosurgery, where you do smoothing of the bone. Can you see the irregularities over here? So you do the subtractive osteosurgery. Now, by definition, regeneration or substitution of the bone is additive osteosurgery.
Hold up.
Whereas subtractive osteosurgery is resection or the removal of the bone. Now, again, in subtractive osteosurgery, there are two types. Okay, you have definitive and compromised. In definitive, you're not compromising the tooth in any way. Okay, you're just doing a very minimal to just maintain the contour of the bone. Can you see over here in this picture? You're just maintaining the contour. Your teeth is not compromised. The bone support for the teeth, like this bone support around the tooth is like very strong. You're not compromising it in any way. Just reshaping of the bone. So that becomes your definitive osteosurgery, subtractive osteosurgery, where establishment of positive or normal physiological architecture of the bone. Now, in compromised cases, what happens sometimes when you do like different kinds of treatments, you have corticotomy cuts which you need to give. Like example, in this orthodontics, they have given corticotomy cuts between the teeth. Okay, that way the support of the tooth is actually lost, but it's for the betterment of the future because they want faster movement of the teeth to happen. Okay, so that's where it's called as compromised subtractive osteosurgery. Okay, so these were the different types. We have additive, we have subtractive osteosurgery. Under subtractive, we have definitive, and we have compromised. Okay, now a quick question to all of you all. Where do you think, in which condition typically requires a combination of additive and subtractive osteosurgery for correction? Anybody knows this answer, like over here? Is it in osteectomy, socket preservation, Wilckodontics, pocket reduction? Okay. So there is one procedure which is called as Wilckodontics. Okay. In Wilckodontics, we do both additive as well as subtractive osteosurgery. So why Wilckodontics? Let me show you. Okay. So can you see the procedure over here? So in orthodontic cases, what they do is they do all these small cuts, and also can you see the small dots over here? That also they do it with a small bone burr, they call. Okay, they do all those dots over there, and on top of that they add the bone graft. They add the bone graft, they pack it up, and then they close it. Now, why they do this? Like, why do you require this? Why simply cut again and then again bone graft is added? Why all that? Because of the reason being that in orthodontic, you need tooth movement to happen. So when you give these corticotomy cuts, the tooth movement happens faster. So if you're taking 1.5 years for an orthodontic treatment, it has months of span, you can finish the orthodontic treatment. That is because of this. This itself is called as periodontally accelerated orthodontics, PAOO. Okay. So that it's also called as Wilckodontics. So bone graft is added again for regeneration of the lost bone. So that's where this is one of the procedure where you require additive as well as subtractive surgery. Okay. Next, let's come to objectives. Objectives, again, the primary objective will be the elimination of the periodontal pocket. So, because to remove any osseous deformities and create the physiological contour of the gingiva, it's the repeat of the same what I was talking. So, it's just to come back to the normal physiological contour. Okay. Then other objectives, of course, elimination, because again to create a shallow gingival sulcus which is readily maintained by the patient. Then a periodontal tissue contour. When you have the nice bone contour, the gingiva also adapts to it very well nicely, and it's easier for the patient to maintain itself. Okay. Then to create a gingival contour, as I told you, bone contour, if it's good, again your gingival contour also becomes very good. Then if you are opening the flap, if you have a nice bone contour, it's easier to close the flap as well. And to additional crown length, when you place in prosthodontics, when you have that tooth crowns which you place, if they have like extra where they don't have enough gingiva, so what they do is they lift the gingiva, cut little bit bone, and then close the gingiva, and then they place the crown. So that way you're making more space for the crown to go in. So that becomes to create additional crown length for when placing the this thing. That becomes your objectives. Okay. Next, now in which cases will you select factors in selection? Let's quickly go through it. I have added the mnemonic fabric over here. So first of all, as discussed earlier, furcation involvement. For A, we have alveolar marginal bone architecture. So if the bone architecture is there, based on that, you can decide if you can do resective osseous surgery or no. Then different types of bone defects. Each defects you'll have to calculate the positives, the prognosis, if it's good or bad. Based on that, different types of bone defects you can decide. So that becomes your B. R, root form and morphology. How your root form is, what are the existing walls, osseous walls present around the tooth, all that. Then your I becomes your inclination of the teeth, as we have discussed before again. And the fifth one, configuration and the depth of the bony lesions. So that becomes your fabric. Once again, let's just revise. Furcation involvement, alveolar marginal bone architecture, if there is a bone defect, root form, inclination of the teeth, and configuration and depth of the bony lesion. Okay. Now that becomes your factors in selection. Now, resective surgery, clinical applications. Clinical applications, I'm not going in depth as such, but I'll just go department wise to show you like where it's required and probably you can use it. In periodontology, if you see, of course, pocket reduction, osteectomy, osteoplasty, again for a smoother flap closure, altering any bony exostosis. We have bony protuberance, which we saw if we want to flatten that. Any ridge deformities, even that narrow ledge, which I showed you previously, that. Coming to endodontics. Endodontics, let me just close everything so that I can open one by one. Okay, endodontics and restorative dentistry, exposing the dental caries when you have subgingival caries, but you don't, it's not visible. So you open the gingiva, but the bone is also covering. So that time you have to do a little bit of bone removal to expose the dental caries. This especially happens in radiation caries. Like after oral cancer, when they undergo radiotherapy, they have radiation caries, right? So that becomes very subgingival. So it mostly every time you have to cut the bone to see your extent of your radiation caries. Okay. Then prevent invasion of the biological bit. Biological bit we know again. If we place the crown, we need to know the sulcus depth. There has to be minimum of 2 mm difference between the sulcus depth and the bone. So again, we need to remove a little bit of bone to maintain the biological width. That is endodontics and restorative dentistry. Coming to prosthodontics, implant placement. We need to do some removal of the bone while placing the implant. Probably bone augmentation. If you want to add extra bone around the implant, all that happens. Then crown lengthening. When you're placing the crowns, if there is no enough place, you remove a little bit of the bone around the tooth, and then you place the crowns. So prosthodontics. Coming to oral and maxillofacial, removal of impacted teeth. Almost every impacted teeth will be covered with bone. So you will have to remove the little bit of bone. Then you can see the little bit of third molars over there, and then you try to remove it. This is example third molar. It can be any other impacted teeth as well. Socket preservation. Socket preservation, why do we do it? Anybody knows? Socket preservation? Okay, socket preservation again. We add in more bone graft. So basically, okay, quickly let me brief it up. Socket preservation is basically you extract the teeth. There is an empty socket over there. You clean nicely so that no infection, everything is there, and then you add bone graft to it, to the socket. Okay, and you pack it up. You tie it up. After 3 to 4 months, there is fully bone is grown over there. Now, why do we do that? Because when you have the bone, there is chances where you can place the implant over there. If you don't have the bone, the socket, the bone resorption happens, and then you can't place implant over there. So this is one of the treatment options for implant placement, where we preserve the socket. We add in more bone graft, we close it up, and then we wait for 3 to 6 months to get like nice bone gain over there, and then we place the implants. So that is in oral and maxillofacial surgery. Coming to orthodontics, Wilckodontics, as I discussed once before, and again, removal of any canine which is impacted, and for any tooth exposure, if it is like deep down in some cases, and corticotomy procedures, like if you want to move only one teeth, so that time you just do cuts in that one teeth over there so that it moves faster. So that is in orthodontics. Okay. Now, this much is the resective osseous surgery. This is the normal bone morphology which we discussed. We discussed the definition over here, and it is caused by periodontal disease and the other related factors like exostosis, tooth eruption, etc. And then we spoke about indications. Indications, all these are indications: exostosis, ledges, shallow bony defects, grade 1 and shallow to furcation defects, bone contouring, and to achieve the primary flap closure. Then we talk about contraindications, where aesthetic concerned areas you have to be careful, severe bone loss you have to be careful, root hypersensitivity, close proximity to the maxillary sinus, near the ascending mandibular ramus or external oblique ridge. So indications and contraindications. Then types, two types: additive osseous, and again in additive and subtractive. Subtractive, we have two types, that is definitive and compromised. Okay. Then coming to objectives, we have primary objective to remove the deformities that is there, and then the other objectives: elimination of periodontal pockets. See, the main objective of resective osseous surgery is to make the patient maintain the oral health very easily. So anything which is hampering that needs to be removed. Okay, so that is the main objective of this resective osseous surgery. Then coming to factor selections, which we saw, we have furcation involvement, and under the name fabric, we learned furcation involvement, alveolar marginal, bone architecture, bone defect are for root form, inclination of the teeth, and configuration and depth of bony lesion. Then resective surgery clinical applications, we have in different departments, each one. I think I need not go there again. But any of you all have any doubts? Wilckodontics. That's a beautiful topic, actually. I have an entire 200-page book of Wilckodontics. What do you want to know? So basically, when a patient comes for orthodontic treatment, it becomes difficult for sometimes when they have wedding. Okay, they want treatment faster. They want the treatment, but it takes at least 1.5 years. They don't have enough time. So that time we give the option of Wilckodontics. But all that being said, it's hardly done in India. It's done outside India extensively. But here, the patient acceptance is very less. Okay. Now, that being said, let me just project the picture over here. Okay. Now, in this picture, when you see, now this patient has come with this. Now, for further treatment, we do bony cuts over here. Okay. When we do bony cuts, and along with that, we do bony, like, can you see we use bony burr and we make small, small dots. Now, when that happens, so there's something called as CAP, that is corticotomy assisted periodontics. It's called whenever surgically, when you remove a bone, no, the regeneration of the bone happens faster. Basically saying that in a sterile condition, when you do any bony cut, no, the regeneration of that bone happens faster than any other part. Okay, based on that concept is Wilckodontics. So they are saying that when you do this cuts, no, the regeneration of the bone happens very fast. So on top of these cuts, when you're putting all this arch wire and you're bringing it to the arch, the regeneration of the bone happens in a fixed form where you need the arch to be like, in a proper nice archway. However, the occlusion, the final occlusion the orthodontist wants. So what happens is the bone regeneration happens in such a way where it is already in the set arch. But in a normal orthodontics, what happens? You have to move the teeth. So if I start talking about that, it'll take some time. So basically, when in normal orthodontics, when you move the teeth, right? So one side you're pushing the teeth. So this side of the teeth, whichever bone has, there is resorption happening of the bone. When same time there is addition of the bone over here. Okay, correct. So that's how tooth movement happens. So that when you're doing with exactly pressure tension theory. Okay, there are different theories to it, right? So that is one of the theory. So the same concept happens at an accelerated or a faster version when you do it in Wilckodontics. When you're doing placing the cuts and you're placing the bone graft. Like, it is, they say it's 6 times faster than the normal orthodontic times. So that is Wilckodontics.
Thank you, ma'am.
You're welcome. Anita, right?
Yes, ma'am.
Okay. Anything else you want to know in Wilckodontics?
मैम बस इतना ही पूछना था, समझ नहीं आया था पेरियोडोंटिक्स पार्ट.
ठीक है. Any other questions? When will we get the mind map in the group? I think that Palak has to answer if she's there online.
Yes, very much. As soon as the session gets over, we'll send you the copy of the mind map. Somebody wants you to repeat types of subtractive osseous surgery.
Yes. So, subtractive osseous surgery is, there are two types, definitive and compromised. Okay. In definitive, mainly these two are divided at the base of, are you causing any harm to the surrounding structures of the tooth, or is there no harm? So this is the main concept. Okay, so in definitive, when you see, no, you're just reshaping the bone over here. Okay, you're not causing any compromisation for the supporting tissues of the teeth. Like, you're not causing any harm where it might lead to further, mobility of the teeth or recession of the teeth or anything that sort. You're not causing. So basically, no compromisation is happening. So that becomes your definitive treatment, where your establishment of a positive or normal physiological architecture of the bone. Whereas compromised becomes, it is removal of extensive bone. It can be, this is one of the example which I've given, but it can be at some cases, what you have to do is you have to reduce the bone because it is damaged by the periodontal disease. So you have to cause like some removal of the bone for you to, for easy maintenance. But at the same time, it is compromising the support of the teeth as well. But there is no other option. Like, you have to do that for the longer prognosis of the teeth, longer good stability of the teeth. So for that purpose, you're compromising the surrounding tissues of the tooth. So that way it becomes compromised. So removal of extensive bone, which leads to a reduction in the bone support of the teeth. So that is the two types of subtractive osseous surgery. Is it okay?
Wait, there's more. But before we go further down the rabbit hole, subscribe to our channel.